All right, well, we're going to get started now. So welcome to Grand Rounds. This is our penultimate Chief Resident presentation by Dr. Houghan, and delighted to have all of you here towards the front. I'm very excited. Great turnout. Thank you all. And to introduce Mike, I am going to hand the mic over literally to Dr. Andy Coyle, our awesome residency program director.
All right. So really excited to be introducing our Grand Round speaker today, Dr. Michael Houghan. So Mike is a graduate of the University of Michigan and then completed his medical school at the University of Toledo College of Medicine and Life Sciences. He obviously did his residency here at UW as a member of our primary care program. As a resident here, Mike really distinguished himself as an outstanding clinician, a really remarkable teacher, and then a scholar working at projects at the intersection of medical informatics and medical student education. As our primary care program chief resident for this academic year, Mike has been a wonderful mentor and role model for primary care, for both our primary care residents and our categorical residents. A really exceptional teacher teaching across our entire curriculum. And as we'll hear today, a really innovative medical educator with a focus on ambulatory point of care ultrasound. We are very lucky that Mike will be joining the faculty here at UW as a member of our Division of General Internal Medicine. He's been a wonderful colleague at Union Corners and really glad that I selfishly will have a chance to work with Mike even more. So really excited to hear his talk today, placing the focus on outpatient POCUS. And so please welcome today's Grand Round speaker, Dr. Michael Houghan.
Thank you, Andy. That's very nice. You guys hear me okay in the back? All right. Well, I feel very honored to be able to present my Grand Rounds to you all today. I'm going to speak to you about placing the focus on outpatient POCUS. And just a point of clarification, as Andy had talked about, POCUS stands for point of care ultrasound, and I'll be referring it to as POCUS throughout because it is both shorter and more fun. And so just know that throughout the talk. And I'm going to do my best to make this hour worth your time. Here, I have no disclosures. And here are my learning objectives today. So upon completion of this lecture, clinicians will be able to summarize the evidence supporting POCUS as a diagnostic tool for internists, apply a model to develop research questions for a medical education project, describe how a curriculum focused on outpatient exams can improve resident knowledge and confidence in using POCUS, and identify the barriers to implementation of POCUS in the outpatient setting. So we'll go through my outline here, and today I'm going to walk you through how POCUS came to be and how it got into the hands of internists, and I'll perseverate on history for a while if you allow that. And then I'll discuss some of the evidence that we have for its use in the inpatient setting, and then now what evidence we have for outpatient practice. And lastly, I'll explain my current chief year project and where I see this project and POCUS as a whole going in the future. But first, I do want to start off with a little story, as to me, medicine only makes sense in the context of stories. So this was me on June 24th, 2020, which was my first day of residency. As I was heading out the door, my wife made me pause and take a quick picture. As you can see, I had like this little notebook thing that I thought I was going to use. Did not use that. And so I was starting at the VA emergency department for our very first shift, which, as I see a lot of residents in the room know, is a place that we feel great ownership over, but is also generates maybe a lot of fear in us as well too. So on my first day, I was working with one of our awesome ER docs. And for my first patient, she very kindly and helpfully helped me through the dosing of Tylenol. But on my second patient, we had something a little more complex. We had a veteran who came into the emergency department with worsening shortness of breath and a history of heart failure and COPD, a very common presentation in our emergency department. As the earnest new intern, I obtained a very thorough history, but I still couldn't really come up with an answer. So then I moved on to the physical exam. The patient had chronic lower extremity edema, really not sure if it was getting worse or better. And he had kind of a thick neck, so I couldn't really evaluate his jugular venous distension. And I couldn't really make heads or tails of his lung exam. So then I go back to my attending and we kind of work through, the most dangerous stuff. And we go through this workup and we've ruled out the most dangerous things. And we've narrowed down our differential to COPD exacerbation or a heart failure exacerbation, which again is the classic medicine standoff. Do we diurese or do we give steroids? And in this setting of clinical uncertainty, my attending gave the suggestion that maybe we should just POCUS him. And I had no idea what that meant, but I did nod along like I did. And I watched as she quickly placed an ultrasound on the patient's neck, abdomen, and thorax that helped to point us towards a diagnosis of heart failure exacerbation. We were quickly able to give IV diuretics right on the spot. And after a few hours, he was feeling much better, and we sent him home. I was amazed at the clarity and speed at which POCUS gave us more data to our history and physical in the setting of this clinical uncertainty. And then residency happened, and I kind of just quickly forgot about all of this. But through my training, I really decided that this is the kind of doctor I really strove to be. This is the famous painting, The Doctor, and I really wanted to be that guy who was an ardent professional who was called upon to think through the hardest problems during the most difficult time in a patient's life. And I think that's really what drove me to be a general internist. And even now, as I've been transitioning to a chief resident role, I really have been thinking more and more about how we think through these processes. How do we come to our conclusions? And how do we train our future internists to become better diagnosticians? And even from then, I've been thinking now, how do we even obtain our data for our conclusions? What evidence do we have that guides our physical exam maneuvers? And how does POCUS fit into all this? So when we think about physical exam, we do have the 4 pillars that we all classically know. Inspection, palpation, percussion, and auscultation. Inspection and palpation have been the mainstays of the exam of patients since the dawn of our profession. But for percussion and auscultation, this wasn't always the case. Someone had to come along and display that this was really worth our while. So this is Dr. Leopold Olmberger. He was the son of an innkeeper and a Viennese physician. And in the 1750s, he developed the technique of percussion while tapping on wine barrels in his father's cellar. He noticed that tapping over fluid versus air made different sounds, and he could apply this to the thorax. At least that's what history, or that's what legend tells us. He did write upon this, and his writings were immediately rejected. Nobody cared. Nobody was interested. He was ignored for the next 50 years. Until French physicians came along and looked and read his materials and noticed that maybe this could be a good teaching technique. And then looking at it further and further, they found that actually it was really useful for the diagnosis of pleural effusion. And our use of auscultation has also changed over time. This is a hospital worm during the chief physician's round, since that's not really what a chief resident looks like. I know we age, but it's not that quite. This is immediate auscultation, as shown here, placing the ear directly on the patient to listen. This has been also going on since the time of Hippocrates. In his writings, he said, "You shall know this, that the chest contains water and not pus, if in applying the ear during a certain time on the side, you perceive a noise like that of boiling vinegar." And we all know what boiling vinegar sounds like, right? So highly sensitive and specific. But real auscultation as a true science did not come through until René Laennec, a French physician, developed his stethoscope. This dawned the age of mediate auscultation in 1816. So now, just like Dr. Laennec here, the expert diagnostician could more clearly appreciate, as he called it, every aspect of sound of the thoracic viscera. And over the rest of his career, he continued to work to characterize heart and lung sounds and correlate this to actual disease processes, because he was not beholden to his specific instrument, but to the pursuit of diagnostic accuracy. And just like with percussion, unfortunately, nobody really cared. The English actually were angry about it and were very against it. But one of the early adopters was Dr. William Stokes, who you may know of Shane Stokes' breathing fame. And he advocated for its use for both diagnostic purposes as well as a tool for teaching. He said, mediate auscultation, like truth, does not shrink from inquiry, but on the contrary, courts investigation. Her advocates only demand a fair trial. And these four pillars have really carried us into the modern era. When we think of a physician, we think of a keen observer with a stethoscope in hand, and he is the diagnostic wizard. But is that actually true? This special communication was released in JAMA Cardiology in 2018, which declared that it was time to add a fifth pillar of the physical exam. And they made several arguments about this. They said that current physicians are just not as proficient with the use of the stethoscope as previous generations. And they gave lots of reasons behind that. Patients are just more complicated. And it's not as straightforward as what we used to see on stethoscopes. And when the stethoscope first came out, what we were seeing was late-stage disease presentations that were really specific findings. And those people who had been providers in this late-stage disease presentation, they keep retiring. And so we don't have them around to teach our new learners. And we do have CT scans and MRIs that are better at diagnosing than a simple physical exam. And so with all of those reasons, trainees are just not as interested in mastering this physical exam. It takes a lot of effort and time. Is it really worth our while to really learn this really hard maneuvers? And so looking at this, I do kind of believe their arguments. I'm a current learner, I would still say. And so all of this does make sense. But what does evidence point us towards currently? So this was a meta-analysis from Denmark that pooled sensitivities and specificities from different pulmonary pathologies and then correlated with breath sounds from 35 studies. Abnormal breath sounds were seen as highly specific, but had a sensitivity of less than 50% across all pathologies. That's outside of trauma, but we don't really deal with that. But things like heart failure, pneumonia, obstructive lung disease was really not very sensitive with the use of the stethoscope. And this is what the study designers concluded. We must reconsider the use of stethoscope in patient groups with low prevalence of disease and in clinical situations where more advanced diagnostic modalities are available. Only in clinical situations in resource-limited areas with high prevalence of disease and in experienced hands, the stethoscope has some clinical relevance. Now, I don't think many of us feel this severely about the stethoscope, but I think this does give me pause at least. Really, if the stethoscope alone isn't really that great at narrowing a differential, what's next? So this is Dr. Daniel Lichtenstein. This was a black and white photo, but this was taken in the 1990s, so it's not that old. But he's a French physician who is thought to be the father of the clinical ultrasound. In 1985, he was working a shift in the ICU where one of his patients was decompensating. He ordered a chest X-ray, and unfortunately, it was inconclusive. So, because he had some experience with ultrasound as part of his medical school training, he snuck into the radiology department and wheeled an ultrasound to the patient's bedside, and he was able to visualize a pleural effusion. And so he was able to initiate treatment swiftly, and the patient got better. This categorically changed his path in medicine. He's now worked tirelessly over the last 30 years, just like Leonek did, to corroborate his various ultrasound findings to CT scans to show that this can be used in clinical settings. So now let's go back to basics here and talk about some definitions. Point of care ultrasound is the practice of clinicians using an ultrasound at the bedside to guide clinical decision-making by narrowing differentials, reducing uncertainty, and guiding therapies. It is a real-time focused assessment at the bedside of patients with suspected pathology. It differs from consultative imaging in that the exam is hypothesis-driven and it's meant to answer binary or graded clinical questions that could immediately impact care. And lastly, the clinician is the clinician who asks the question is the one who performs the POCUS exam and then uses the answers to guide their clinical care. In that way, it's really great for quick multi-system evaluation in complex situations, like when there is concern for shock. And you may ask, how do ultrasounds work? And I think it's a great question, and it's really complicated. But I'll give you the spiel that I give to my residents here. Ultrasound machines generate images via what's called the piezoelectric effect, which is when crystals within the transducer, they vibrate against each other, and that helps them to generate sound waves at a specific frequency. I'm guessing you can guess ultrasound frequency. These waves then penetrate through the body and then return to the transducer as reflected ultrasound waves. And then the machines convert this to image so that we can see what's going on. The image is truly dynamic and in 3 dimensions. So the image will change based on your angle of insonation, and the brightness of the image depends upon the density of the tissue that it penetrates. So for example, as you can see in this image here, we're looking here at the long axis of the kidney. Ultrasound probe is faced in this direction and will penetrate here the kidney, and then the waves will bounce back. And this is the image that penetrates here. You can see this is the kidney here, and the brightness of different parts of the anatomy here depends upon the density of the cortex and the medulla. So the story of POCUS mirrors the introduction of lots of other parts of the physical exam, as I was talking about here, with a physician kind of going out on a limb, trying something new, being rejected immediately, and then working tirelessly to corroborate its use with evidence. So I think it does fit nicely as the 5th pillar of the physical exam here, as those cardiologists said in JAMA in 2018. But really the question is this something that can really be standardized across medicine? And that's really the question that I asked during my 3rd year of residency here, as I saw in my primary care clinic an eerily similar patient to the one I had seen in the VA emergency department as an intern. And I quickly remembered the amazing clarity and speed that the ultrasound brought to my already thorough history and physical in the face of clinical uncertainty. So I talked with my attending at the time, who happened to be Dr. Kelly Lavin, and I said, wow, it would be great if we had POCUS in clinic. And she agreed. So she recommended that maybe I start asking some questions. And first, we decided to ask some big picture questions. Why would we want to use POCUS in clinic? What outcomes would we be hoping for? And so we decided we wanted to see if POCUS would improve our patient care, improve our patient satisfaction, improve provider satisfaction, and decrease healthcare costs. And later, actually 3 weeks ago, during her grand rounds, I learned from my co-chief, Dr. Carolyn Berkey, that this actually makes up the quadruple aim of healthcare. And next, we thought about all of the possible applications that we could consider for primary care doctors. After attending a 3-day in-person ACP course for outpatient internists, this is what we came up with, kind of a big list. But if we were going to try to use all of these applications, we felt that a dive into the literature would be necessary. And I'm going to try to do my best to do that here and synthesize the most important stuff for all of you to kind of understand why I feel like this is useful. We'll first start with the lung exam, which kind of has the most evidence behind it. And I'll kind of quickly go through, I think, what's the most important. So this table is from a meta-analysis by Wang and others in 2018. And it described pooled sensitivities and specificities for various acute respiratory pathologies and compared stethoscope with chest X-ray and point-of-care ultrasound. While we already discussed that chest X-ray and percussion are highly specific for pleural effusions, point-of-care ultrasound is equally specific as those and more highly sensitive. Also, looking at pulmonary edema and pneumonia, POCUS is more sensitive and specific for both of these pathologies than stethoscope and chest X-ray, with POCUS in the upper 90s for both sensitivity and specificity for the diagnosis of pulmonary edema, and in the upper 80s to 90s for the diagnosis of pneumonia. There is also substantial evidence for its use for cardiac exams as well, which most of our residents know, who I'm seeing a lot in the audience. This table is adapted from a study of 250 patients where 2 cardiologists evaluated each patient, one with a physical exam and one with point-of-care ultrasound. This table shows the percent of the time that the examiner's conclusion was correct. As you can see, POCUS vastly outperformed classic physical exam in the evaluation of reduced ejection fraction, abnormal RV function, and moderate to severe valve disease. Now, I'm not going to spend a ton of time talking about POCUS cardiac exam because I think we all are pretty well aware that a TTE just gives us a lot more information than the physical exam would when talking about the heart. So really the question is, with how long it can take to get an echo these days, how does POCUS compare to classic TTE? And this study specifically trained both internists and cardiologists to use POCUS to detect several cardiac abnormalities, including valvular abnormalities, LV dysfunction, RV dysfunction, pericardial effusion, amongst others. They then had 200 patients undergo both TTE and POCUS exam with both the POCUS physician and the echo readers blinded to each other's results. Compared to TTE, the detection of abnormal findings using POCUS was about 90%. Okay, so I think that's all great evidence and all that's awesome, love to see, but you might say, Mike, was from hospitalists and cardiologists. Can we really extrapolate this to outpatient internists? And I would say that's a good question. I'm glad you're paying attention. Thank you. And I do think we have to reconsider this as we're reading these articles. We know that patients in the hospital are different in lots of ways to patients that we see in clinic, and disease prevalence is different between the clinic and the hospital, which makes these calculations of sensitivity and specificity imperfect. But I would argue that many of the patient presentations that we think are different in the hospital are not that different from what we see in the clinic. POCUS is used very frequently in the emergency department, and I would say that I do see undifferentiated dyspnea, pleural effusion, pneumonia, heart failure in my clinic all the time. And so I think that's an important factor to think about, that while we think that they are very different, I think that our patient presentations are rather similar. I do think that it would be great to have some targeted literature, though. And so maybe we should focus on an exam where ultrasound is already the standard of care. So in clinic, if we have high suspicion for DVT, what would we do? We would send our patient stat to the emergency department. They need to get an ultrasound by the end of the day. But what if we were trained to do it in clinic ourselves? This was the PRACTICUS study, which was a multi-center prospective blinded cohort study that had all patients who presented to clinic with a suspected DVT first undergo point-of-care ultrasound by their PCP in clinic, and then were sent to get ultrasound, a standard ultrasound, that was then read by a radiologist. And here are our results. POCUS, as you can see here, was highly sensitive and specific, with a very high positive likelihood ratio and a very negative likelihood ratio, very low negative likelihood ratio. And agreement between the two evaluators was excellent, with a Cohen-Kappa score of 0.86, which is an evaluation of inter-rater reliability. So now we've gone through evidence behind these 3 applications here in red, but we do have many more to discuss. And it's already 8:25, and I think we would be here till like 4 p.m. if I talked through all of these. So I'm going to do some rapid fire, so bear with me for a minute here. All right, abdomen. Here, what we're looking at here, liver and gallbladder. POCUS has 90% sensitivity and an 88% specificity for the detection of cholelithiasis. I have more abdomen now. Okay. POCUS has sensitivity and specificity in the detection of intraperitoneal fluid of 90%. And here we got kidney here. While POCUS is not as sensitive or specific as CT scan is for the detection of kidney stones, many emergency departments are now moving or considering to move to a POCUS first model, as this would allow them to potentially reduce costs, but also to reduce radiation burden while they're still catching about 75% of cases of kidney stones. All right, now I have skin. This is what skin looks like. POCUS can be used for a wide variety of skin abnormalities. It's really great and easy to view things with a vascular or linear probe. And this can include foreign bodies, cysts, lipomas. And it's also really awesome at when you have a patient who's coming in with cellulitis and you're not sure if there's an abscess. It's really awesome at ruling out abscess when you're evaluating for cellulitis as a very high sensitivity. And lastly, we'll talk about the wide variety of MSK applications. This is, I think, really the meat of where we can have our primary care doctors move forward. And these are the applications that we've learned as part of our, Dr. Lavin and I, as part of our ACP course, and we are currently teaching our residents as well. And we do have, there's lots of other applications as well. Okay, I know that was a lot and I moved through a lot of that very quickly. If anyone's interested in the full evaluations, I'd be happy to talk about it later as well too. But let's get back on track. We discussed how POCUS can improve patients by improving our diagnostic accuracy. Now can we show that we can improve patient satisfaction? And kind of talking from our initial thoughts, we thought that POCUS would increase patient satisfaction by enhancing provider diagnostic abilities during a clinic appointment, reducing diagnostic delays, decreasing the need for imaging orders, and decreasing healthcare spending. To me as a patient, this sounds really great, and I'm hoping that we could be able to find those things. Here's one study that was done in the emergency department that aimed to evaluate whether POCUS correlated with patient satisfaction. This was a single center randomized trial where 70 patients either were selected to have POCUS performed or not during their emergency stay. Then 1 week later, they were called to fill out a survey. The POCUS group had significantly higher overall ED satisfaction and the perception of the skills and the abilities of the physicians. In a Danish study in 2021, family physicians surveyed 600 patients after they incorporated POCUS into their care. 95% of patients reported that POCUS improved their overall level of care. They felt that POCUS gave them a better understanding of their health problems and increased their trust in the physician's assessment. So next is to discuss whether POCUS can improve provider satisfaction. And one difficulty when I was doing my literature search about this is that, again, at least in the United States, more globally, this is more common, but in the United States, POCUS is just not utilized as much in the clinic right now. So we decided to look towards the future docs, the docs who would be using this in clinic. A 2021 survey reported that 73% of medical schools now have ultrasound embedded into their curriculum. And that's more than doubled since this was evaluated the last time in 2014. Graduates from medical school continue to expect opportunities to learn and to advance their POCUS skills that they learned in medical school. And survey of residents across multiple institutions demonstrate that greater than 90% of internal medicine residents are interested in learning POCUS, and they perceive real shortfalls in the availability of training in residency. And lastly, most residents have had experience with holding a probe and could easily get their hands on this. Butterfly, which is probably the most popular POCUS out on the market right now, currently has a $2,600 option. And while that is a lot of money, I think that is something that young faculty or learners who have a couple extra bucks could be able to obtain and could use in clinical care. And in 2019, UC Irvine gifted all medical school graduates with a handheld ultrasound. And I think that's cool. But we need to prepare these residents to use this correctly and judiciously. POCUS, I think, is a really awesome tool. Obviously, I feel that. I'm talking about it. But it is something that, if not used correctly, can have real harms. And I will say, as speaking as a very recent resident, I find performing POCUS viscerally satisfying. We spend a lot of our time as residents glued to the EMR, but it allows us to peel ourselves off, go see the patient, evaluate a concern, narrow our differential. And that's really what we came to internal medicine residency to do. And I think as we see nationwide difficulties of trying to recruit our best learners to general internal medicine, I think if we prioritize this tool that's very popular, potentially maybe this can show or help to show our learners to see that GIM can be cool too. So lastly, what we're going to look at here is, can we show that POCUS can improve the efficiency in our system with reducing real healthcare dollars? So I'll start as a caveat that there's not a ton of evidence out there right now that supports this, but the POCUS cohorts across the nation strongly believe that eventually, in the long term, this will show some benefit. So here's a recent study that was a single center prospective cohort study that compared inpatient teams in the hospital that either had POCUS available or did not. Results showed that the availability, just the availability, whether or not it was used or not, of POCUS with a team was associated with a meaningful reduction in total hospitalization cost, radiology cost, and total chest x-rays for these hospitalized patients. So I think that's some real good information that we're getting here about inpatient teams. I think that more studies are needed to see here if this can really change outpatient costs. So now that we went through this deep dive in the literature, a few things to me, at least, stick out. I think it's clear that POCUS has a lot of evidence on the inpatient side and has some evidence on outcomes in the clinic setting, but still lacks some good, clear evidence for lots of different outcomes. And I had never built a curriculum or developed research questions before, so this was a pretty daunting task to me. But I knew that I wanted to build a curriculum that would benefit both our residents, but also contribute to outpatient POCUS evidence as a whole. So I needed to think about how I would evaluate that. So this takes me back to about second year. And during one of our Teach Pathway journal clubs, our leader, Dr. Zielinski, asked us about Kirkpatrick's 4-level evaluation model, which I'd never heard about, but learned about as part of this journal club. And this is a tool to develop questions that would best evaluate our curriculum and impact educational research. Kirkpatrick tells us that level 1 is our lowest impact evaluation, and level 4 is our highest impact. Level 1 asks the learner to evaluate the training. Level 2 asks, did this training increase skills or knowledge in the learners? Level 3 asks, did this training cause a change in behavior? And level 4 asks, did this training lead to a greater impact on our patients? So here is what we came up with. I know this is a lot of words. I'm going to walk through it quickly here. So we were asking, by creating and teaching an outpatient-focused POCUS curriculum, can we increase resident satisfaction and confidence with POCUS education? Can we increase resident POCUS knowledge and skills? Can we increase utilization of POCUS in the outpatient clinic setting? And can we increase all these patient-centered outcomes? This would allow us to evaluate all 4 of Kirkpatrick's model and touch base on all 4 of those 4 main POCUS goals that I talked about earlier. And from these questions, we then developed our project. Because of the high-level questions that we had, we knew that it would, and the fact that we knew that it would take some time to obtain an ultrasound, we developed kind of a graded plan to answer these questions. This year, we'd focus on building our curriculum, teaching our residents, and then we would focus on those high-level topics next year. And we focused on topics that we felt both had good evidence for use in clinical decision-making and would be useful for the outpatient setting. And we split them up into then 4 different workshops. And these are the workshops we had. We did cardiopulmonary ultrasound, then abdominal ultrasound, which included liver, gallbladder, free fluid, bladder. Vascular ultrasound, which included AAA, DVT, and volume assessment. And then skin and soft tissue, which included knee, shoulder, MSK, which included knee and shoulder, and then skin and soft tissue exam. So to evaluate our curriculum, we now would just focus on our level 1 and our level 2 questions. Can we increase resident satisfaction and confidence with POCUS education? And can we increase resident POCUS knowledge and skills? And we opted to use pre and post session surveys to evaluate this. And we evaluated each participant on general knowledge of ultrasound, their knowledge of general anatomy and ultrasound windows, and their interpretation of different images. And before each session, the learners would complete a pre-session survey, and then they would complete online ACP modules that corresponded with the specific upcoming session. And then they went to their workshop. And each session within the workshop included a 1-hour lecture that was run by myself and included a review of things they had learned in the modules, including ultrasound placement, anatomy, and possible pathology, and then a discussion around that. Then followed by 2 hours of hands-on learning with the ultrasound with support from our great standardized patients here at UW. That was led by myself and 1 or 2 other ultrasound trained faculty members, generally Dr. Lavin. They then were instructed after these sessions to perform a post-session survey, at least within 1 week of completion of each workshop, and then with plans to continue to practice this with real-world patients. Now, we weren't able to obtain an ultrasound this year, but that is the plan moving forward in the future. In total, 13 primary care track residents completed our course this year, and I'm very thankful for our primary care track residents that are here and watching or working. Thank you for your support. For the last 5 years, all residents here in our residency program complete an introductory POCUS workshop that I find very excellent when I was an intern, and it's run by our residents here within our program. So many of our residents here, our senior residents here, at least have familiarity with holding a probe, have familiarity with cardiac and lung exam. But outside of this, none of our learners had received formal training. Our new interns had yet to receive any formal training, as the intern course hadn't happened yet. But most residents had some experience with POCUS from medical school. Via the pre-session surveys, the median amount of training experience was 2 to 5 hours. So now we'll delve into our survey results by asking our 2 main questions as we had discussed before. Can we increase resident POCUS knowledge and skills? And can we increase resident satisfaction and confidence with POCUS education? So here is the results of some of the survey questions that were completed prior to any intervention that focused on their interest and their belief in the use of ultrasound. Each bar here represents the average score of survey results as transcribed from a 5-point Likert scale. 1 corresponds to very unlikely, and 5 corresponds to very likely. As you can see, the residents here already had a high belief in POCUS utility for PCPs, internists as a whole, and themselves, which is great. We already know from our lit review that our learners like ultrasound. At a baseline, they already believed that this would probably improve provider and patient satisfaction. And lastly, they weren't really sure how it would affect clinic flow. And so before and after each session, we asked the residents as part of the survey on their confidence level in these 3 factors: utilizing POCUS in assisting with medical decision-making in the setting of diagnostic uncertainty, obtaining proper windows for the given clinical scenario, and describing how an ultrasound probe produces images. And here is the confidence prior to our first workshop, which covered the basics of ultrasound and cardiac and lung exams. So overall, for all of these, if we're looking at them together, the average was closest to the answer of somewhat unconfident for each of these responses. And after our first workshop, the residents answered the same questions, and the scores here are in the orange bars. These, again, were the blue bars that were the same as the previous. And as you can see here, the residents felt significantly more confident in their ability to describe how an ultrasound produces images, their ability to use POCUS as a medical decision-making tool, and ability to obtain POCUS cardiac and lung windows. And this is the same pattern that we'll see again in our second session, which included urinary system POCUS, as well as liver and gallbladder. And then after our third session, which covered AAA exam, volume status exam, and DVT. And our fourth and final session, which included skin and soft tissue and musculoskeletal POCUS exam as well too. And while resident interest, as I showed in that initial bar graph, was already very high at the start, there was an increase, as you can see in the far left bar graph here, there was an increase in belief that PCPs should be trained in POCUS, as the blue here shows the pre-session response, and this was after each subsequent session, a statistically significant increase in this belief, and remained stable in their belief of intrainers and themselves. And by the end of our curriculum, residents felt more confident kind of globally in their ability to use POCUS as a decision-making tool, and felt more confident in their understanding of how POCUS works. And then now, lastly here, before and after each session, I also very kindly asked the residents to take a test and they had to answer multiple choice knowledge questions regarding the covered topic. So here again shows the average results for each session, with the pre-session test results in blue and the post-sessions in orange, which for each of these was a significant increase in their knowledge acquisition regarding POCUS. So I think we believe that our survey results show that by creating an outpatient POCUS curriculum, we can teach our residents to learn and obtain POCUS skills, and we can also increase their confidence in their ability to use POCUS independently and their belief that POCUS can be used by internists nationwide. We know that this data is overall limited in scope, as it's single center, small. There's 13 of us residents. And of course, it is relying on survey data, which is ripe for bias. So this requires us to really pursue more robust measures. I think our next steps would be to look for changes in actual behavior. And so this is the same questions that we had asked at the beginning, I think, is what we're planning to pursue here as part of our multi-year project. We want to continue to teach our residents and encourage their use of ultrasound in the clinic. We know that this procedure, again, requires longitudinal education to reach mastery. And so we'll continue to reinforce this behavior with delivery of an ultrasound machine coming to our clinic imminently, which is very exciting. Next, we'll evaluate for patient satisfaction and evaluate for change in healthcare behavior relating to costs, as we laid out here in level 3 and level 4 of our Kirkpatrick model. Lastly, I want to touch base quickly on kind of the future of POCUS and the barriers to acceptance, because I've talked a lot about how I really think POCUS is really awesome, and I really enjoy it, and I think it's something that's worthwhile, but there are some real challenges. This study here was a survey of all VA primary care centers, and only 13% of primary care centers in the VA currently use POCUS in the clinic setting. As part of the survey, the desire for POCUS training was really high, but a lot of barriers were noted. The most common was a lack of trained providers, but also a lack of ultrasound equipment, which would be a problem, and a lack of funding for both training and equipment. As a whole, also, only 9% of VA centers had any policies relating to POCUS as a whole, both inpatient and outpatient. But most chiefs of their primary care centers would support the use of POCUS and training, about 64%. So I think as part of this survey and as with talking with lots of leaders nationwide, I think our clear #1 issue is that we have a lack of formally trained faculty who can show that they can use this in clinic and then can use that to teach our workforce. And I think that really makes sense. We spend a lot of time learning how to use the stethoscope in medical school, and as people outside of training, it's really hard to learn new skills outside of training. The initial cost and then the maintenance of these machines is daunting as well too. And I think this is also a big question. What is POCUS? I didn't really answer that question. What is POCUS? And that's because I don't totally know the answer. I think many POCUS leaders would say that POCUS is an extension of our physical exam, just like the stethoscope is. But there's real questions. Is this a procedure? Should it be managed like a procedure? Is it imaging? And I think this is something that needs to be decided above my pay grade, but we need to have guideline leading organizations and institutions like UW really decide how to manage this. Also, this requires a lot of practice. I talked about this. It's really hard to learn POCUS. You have to be diligent and you have to be motivated to learn. And we're already very busy people. And so if this is something you really want to do, you have to carve out time to learn it. And let's say we were able to train a workforce. how do we assure quality during all this? It's really easy to pick up a probe, but we need to make sure that we're assuring competency in those who are using it. And I think there's also some real concerns about how it would integrate into the clinic workflow. This is something that's totally new, and how would that work? And lastly, more outpatient studies need to be done. And I have lots of ideas about other inpatient studies that need to be done. These are just a few. I think that what's most important is that we need to continue to connect POCUS to patient-focused metrics. So that would be morbidity, mortality, time to treatment initiation, avoidance of hospitalization, all things that we care about as primary care doctors. In addition, I do, as I'm going to hopefully continue to try to answer these questions, I want to put in a plug for our awesome resident-run inpatient POCUS curriculum that started about 5 years ago by one of our resident leaders and continues to be passed down to senior resident. And they're currently going to pilot a longitudinal curriculum for residents alongside my project, and I'm very excited to see what they're able to find as well. And so for all these barriers, I do have hope. ACP here has recently released a guideline that suggests that clinicians can use POCUS when there is diagnostic uncertainty in patients with acute dyspnea. And SHM has also published support for use of POCUS in hospitalists. And then in 2019, AAIM supported the use of POCUS in IM residency training for both diagnostic and procedural situations. Here is my residents here doing our very first workshop, because I forgot to take pictures after the very first workshop. But here are all of them looking very engaged. And luckily, they were very engaged. They were really a fun group to work with. It's been really fun learning this skill together. One of my residents texted me a couple weeks ago that they had used ultrasound on a patient in the emergency department with one of the ED docs, and they were able to rule out something as part of this, and just felt how satisfying it was for both her and her patient. And that really it just really keeps me invigorated and keep me going, because this is something that can really impact our patients and our learners. So I'm just going to bring it all back here. And I think that today we were able to say that there's evidence that POCUS can be useful for internists in both the inpatient and outpatient settings for the ability to improve diagnostic accuracy and therefore improve patient care, improve patient satisfaction, improve provider satisfaction. And while it's still early, I do believe that we'll continue to find evidence in the future that it will decrease healthcare costs. And I do have a few key points I want to give here. I really do believe that POCUS can be a tool to bring internists back to the bedside. I really think that's important for us internists. And so I do really believe in this fifth pillar of the physical exam. Because really our goal should be just to use what we can use as internists to find the right diagnosis, and what we can use to find it most rapidly and most inexpensively. And I think that includes both the physical exam and POCUS. I'm not here to lambast the physical exam. I think that's really that's additive. And as I think we demonstrated with our data, we can teach learners to use POCUS in the outpatient setting, and we can use this as a tool to get them more interested in both the physical exam and primary care as a whole. And there are real barriers towards implementation. I think it is going to be worth it in the end to work through these, though. And lastly, more research needs to be done to strengthen the evidence of use of POCUS in the outpatient clinic setting, and I'm excited to be a small part of it. Here are my references. Thank you.
All right.
I do want to can I give a brief thanks? I do want to give a brief thanks about people, so might not be brief, but I'm going to try to be as brief as possible. So my wife and I moved to Wisconsin in 2020 for residency. Wow, I did not need to be clapped for that. That was not really. I think my chiefs are already laughing because they know this is going to take a long time. I will not make it long, but that's kind of my thing. We did not know a soul in the state of Wisconsin when we moved here. We found just like a wonderful community here. So I'm really thankful for that. We are both very proud Michiganders, as many of you know. And so we had to think long and hard about what our next steps were after my chief year. And along with my community of colleagues and co-residents, I just can't believe how lucky I was to find like unbelievable mentors here. It just literally felt like I tripped and then there were mentors there. The generosity of UW academic internists cannot be overstated. I just like mentioned to Dr. Schnell that I was interested in medical education research, and then all of a sudden I was meeting with Dr. Zukowski, I was meeting with Andy, I was meeting with Dr. Lavin, and they gave me just so much of their time and expertise to walk me through step by step to figure out how to write grants, to make these research questions. I had no idea what I was doing. And so really what I want to say is that it's very easy for us to get our residents to go to work and see patients and meet their core competencies. But what I think is so unique about doing internal medicine residency here really support the goals of our residents. And I'm incredibly grateful to have matched here. And that's really why I decided to stay here and start faculty in July. I'll also thank my PC residents again for continuing to fill out surveys for me and probably being annoyed all the time. I have loved being your leader. I'm very sad that I won't be your leader anymore, starting here in a couple weeks. So thanks for letting me learn alongside you. And as well as the categorical residents for listening to me on Friday, go on and on about whatever rant I have. And then my co-residents as well too, who helped me survive residency during a pandemic. I can't mention all of you individually, but thank you all. And my year is really defined by my co-chiefs. I hope you're okay with the pictures that I chose. I know you've already heard Carolyn and Kelsey's grand rounds already, and aren't they just amazing? They're just these amazing women that I get to be friends with. Amy will speak next week, and she will show that she's amazing as well too. But really what I'm most happy about is that I'm very lucky to call them my friends. They're great teachers, doctors, thinkers, but really more infuriatingly, they're also like the best people I know. So thanks for putting up with me this year. I will desperately miss losing time in the chief office on Fridays. And speaking of putting up with me, I want to thank my family and the ones who were they really helped me the most time with my grand rounds, which is my cats, Henry and Ruthie, and then our sweet boy, Duncan, as well too. Most importantly though, I do want to thank my best friend and wife, Kirsten, who is up there holding our baby, and you guys did it for a full hour. She has supported me in this crazy prolonged training in medicine since I first decided on a whim to do this in college, then moved with me to Toledo, and then here to Madison. She's the best person I know. She's thoughtful, kind, funny, and she always puts people like myself before herself. So thank you. And I do want to give a shout out to our Genevieve here, who is up there, and she did great. She joined us 13 weeks ago today. I had to leave grand rounds because my wife is in labor, so sorry to the speaker there. Evie has already brought us so much joy. Look how cute. She did go to her first medical conference last week, and so she'll be ready. She's still figuring out what her topic is, but she'll be ready for grand rounds in 30 years. So thank you all. I'm happy to answer any questions. Was that too long? Oh.
And so I assume Evie is claiming CME credit for this.
Yeah.
Get an early head start. I'll open up to speakers. Dr. Schnapp first.
Great. Thank you for a wonderful overview of POCUS. I also believe your research was supported by a Department of Medicine education pilot grant.
It was, yes. Thank you.
So I
Shout
want
out
to
to
make a
that. Thank you
plug
very
for
much.
that for our residents.
As was the resident inpatient 5 years ago was also supported by that. So yes, very much. Thank you.
We support and delighted for this type of academic work. So congratulations on that, and look forward to continuing it. And I believe we are very close to actually getting that ultrasound.
Yes. I've gotten emails about delivery. Yes.
So I have one of the questions, and you alluded to this in terms of the quality assurance. POCUS is very provider user dependent,
Yes.
and depending on the skills. The studies that you quoted with high sensitivities and specificities had a very select group of providers performing the
Correct.
ultrasounds. So how do you think we should evaluate the continued competencies of providers? And do you need to sign off on each organ system, or do you just say, oh, you're good at looking at ultrasound images as a whole, so go for it?
Great question. This is definitely something I wanted to touch base on, but had to cut some things. So thanks for the question. So in order to, there is no standard certification to be POCUS trained currently. And so I think that's stuff that has to be figured out over the next couple of years as this becomes more popular. But in general, there's a couple of ways that, that the recommendation is. So firstly, there are a couple of internal medicine focused ultrasound POCUS fellowships. And so that is one way you can be initially certified. And in general, if that's not the case, in general, what like things like SHM, the recommendation is to go to an in-person course. And then after that, you have to show competency via each organ system. So exactly what you're thinking. So go through a training where they talked about this, but then also perform all of these different organ system based exams, save the images, display your interpretation, and then have someone overread them. The question about continuing like maintenance of certification, I think is a great one. And again, is something that, because this is so new, I don't think anyone totally knows at this point. But that is definitely a question that I think will come out more. And I think will definitely be like this, it'll probably be, what happens in the emergency department is that there is still an overreader in the emergency department of these. And so that would probably be what's happening. There's probably whoever is the lead of the ultrasound in the department will do some quality assurance and will pick and choose some scans that have been done clinically to assure competency while they're using it clinically. It's a good question. It's something that is really complicated, but definitely needs to be figured out for this to be seen as a thing that we can actually do across the country.
All right, great. So one question from online from my current division chief and your future division chief, Dr. Trowbridge. So I think our question was, do you think there's enough volume sort of in our clinics that the future should be that sort of every provider is POCUS trained, or do you see sort of having like subspecialists within the clinics and having a smaller cohort of people who are sort of fully trained in POCUS? What do you see as kind of the vision?
That's a great question. I would say that I'm not saying that every single primary care doctor here at UW should be trained on this right now. I think what I would say is this should be for people who are really interested and really motivated to learn how to do this. I think this is an awesome tool to augment your care. And I think it can improve patients, as I kind of talked about here, and can kind of improve, hopefully, your love of care as well, too. I can't foresee in like 30 years, but I would say like if the ultrasound becomes like the stethoscope and is trained thoroughly in medical school, I could foresee this as being something that is done across the division. But for now, I think that this should really be for those who are really interested and motivated to learn this skill really well, so that the harm benefit ratio is the benefit outweighs the harms.
Great talk. And similarly, if it's in hands of many people and it's part of your regular clinic procedure, should it be recorded? So how do you go back? So if people have phone-based butterflies, but they're going to anchor 3 months of anticoagulation on that decision, where's the sweet spot for that?
Great question. That kind of goes back to the question about what is it? Is it a stethoscope or is it an image? And at these POCUS courses, there's a lot of discussion around that, because there is a lot of, if you are saving an image, that means you need to have a place to save it and you need to pay for that. And you need to, if you're saving that, then it probably needs to go on the record. And I would say what generally POCUS leaders right now are saying is that, yes, you should be saving all of your images. And if, and these need to be read by you, and need to state that as well too on the record. So it should not be, while I'm saying a lot of it is this just an extension of the physical exam? At this point right now, most POCUS experts believe that it should be saved, and we should be able to pull the image in order to say if we agree with your imaging interpretation.
To Mike, if you want to talk more and
Sorry.
connect about POCUS. For those in the audience, you can come on up. So I want to thank Dr. Houghan for a wonderful grand rounds this morning.